Good morning, good afternoon, and good evening to everyone joining us from different parts of the world. Welcome to today's session of the Chorus Urban Health Webinar Series organized to mark World Diabetes Day 2025. Our focus today is strengthening urban health systems to respond to the increasing prevalence of non-communicable diseases with lessons from Chorus work in Nepal, Bangladesh, and Ghana. The world is urbanizing rapidly. By 2050, nearly a large proportion of the global population will live in cities. Yet, this growth is not benefiting everyone equally. Poor urban residents, including people living in informal settlements, often face the greatest barriers to healthcare. As cities expand, behavioral, social, and environmental factors are changing. These changes are driving a rise in non communicable diseases such as diabetes, hypertension, cardiovascular disease. So, in many countries, the poorest urban residents now have worse health outcomes than rural populations. Africa and Asia account for almost 90% of global urban growth. Urbanization is recognized as a major development challenge and is reflected in several sustainable development goals, especially SDG 11, 3, and the goal on sustainable cities and communities, that SDG 11, that's really is crucial for us to address. However, research that offers practical solutions for urban health systems has not kept pace with these changes. Many urban health systems remain fragmented. Several authorities are responsible for service delivery, which affects access to screening, referral pathways, and continuity of care. The urban poor often rely on a mix of public and private providers with little or no coordination between them. So, because of their living and working conditions, and many times these are like informal, many of these communities are not captured in data or policy planning. In Bangladesh, this challenge is made even more pressing by high out of pocket spending on healthcare, and this is true for many other low and middle income countries. So, out of pocket expenditure, which is a significant portion of barrier. Just give me a second, sorry. Sorry. So out-of-pocket health expenditure, as I was saying, this creates a huge, pressure on the family, and the cost of treating the non-communicable disease also expands this burden. So this is where Chorus comes in. Across Bangladesh, Nepal, Nigeria, and Ghana, Chorus works with communities, local government, and health providers to strengthen the urban primary healthcare system and to improve access to non-communicable disease services. Today, we will share what worked, what challenges remain, and how evidence is forming the policy and practice. So, we are honored today that a number of great panelists are with us. Professor Moloy Kanti Mridha, Director of the Center for NCDs and Nutrition at Bragg James P. Grant School of Public Health. We have Professor Said Zakir Hussain, former line director of Non-Communicable Disease Control Program at Ministry of Health and Family Welfare, Bangladesh, and Dr. William Basu, NCD specialist and former professional officer at the West African Health Organization in Ghana. Thank you everyone for being with us. So we'll begin with short country presentations and followed by the panel discussion. So I now request Avigga, Dominic, and Deepa to present, but I humbly request you to be, to manage time. So each of you have 5 minutes. So over to you to present your country experiences. Over to
Thank you, Professor Rumana. Am I audible?
Yes, you are.
Bryony, yeah. So I'll be talking about the lesson from Nepal. Can you go to the next slide, please? So I'll start with the NCD situation in Nepal. So Nepal is one of the Asia's fastest urbanizing country, where 70% of the internal migration is rural to urban. And there has been a major shift in CDs to NCDs in the recent years. Though there are lots of policies, however, major gaps remain in service readiness, equitable access, early diagnosis, treatment, and reducing behavior risk factor. The Housing and Population Census 21-22 shows that the NCD accounts for the major death among all the municipality, also the metropolitan being the highest, it's 3.8 per thousand. And the fourth Nepal Living Standard Survey also shows the same result. And there is a high burden of non-communicable disease in urban areas in both genders. So please, next slide, please. So I'll be mainly talking about the evidence from two cities of Nepal where we are currently working on health system strengthening. The first one is our work at Pokhara Metropolitan City, where we closely work with the government and with help from the embedded researcher. First, we did the need assessment, and our need assessment found that the pharmacies are the primary contact points for the clients, even for the major to minor illness. And public health facilities are they have very low readiness for NCDs. So based on that, we co-designed and implemented the functional linkage model by bringing the pharmacies to the public health facilities to the wider system. And we provided them customized protocol training, which was mainly focused on screening, health information referral, and recording. And this intervention was evaluated in 3 phases: baseline, midline, and endline. And here are few promising results. Most of the pharmacies demonstrated fidelity to pain protocol by implementing all the components, though consistency varied. And pharmacies were also effectively reaching out to the communities for all the components. They were showing better than the public health facilities, and intervention improved better diet, exercise, and medication habits among clients. And currently, the local government has also allocated budget for the engagement with pharmacies. So from this one, the learning that we can draw is that if we can contextually tailor public-private partnership, that will help to improve the service quality, data integration, and health service risk. Now moving towards our next study. Next slide, please. So another study that we conducted is in Budanilkantha Nagarpalika. The main objective of this study is to create the data hub where we can consolidate all the regular data that is from the multi-sectorals in one place, so that it will be easy for the municipalities official to use them in day-to-day basis for the evidence-based policies, to form the evidence-based policies. For that one, we conducted informative study and we interviewed 14 municipal officials from different sectors. Mainly we find out about the gaps and use of data. And we conducted health facility assessment for the readiness, and social mapping was conducted to trace out the major landmarks, health hazard landmarks. And household census was conducted in Ward 4 and 7, that was co-financed by Budanilkantha Nagarpalika. And so we plan to consolidate all this data in one hub. So the early results are here. So from our formative study, we found that most of the department in the municipality, they manage data very independently. Either they were using digital or manual record, and there is no centralized server and sharing protocol that lead to the duplication and inefficiency. And from the household census, we found that nearly half of the adults in both wards are overweight or obese, with substantial proportion also experiencing hypertension, which is 13.6 versus 14.4. And in the past 30 years prior to the survey, about 5.6 of the respondents, they reported that they are having a communicable disease, while around 1/4 were suffering from at least one NCD. These are the self-reported data. So currently we are in process of developing the data hub and finalizing the indicators, and we are having a series of code creation meetings with the municipalities, which will improve the data access for decision making and better targeted health intervention. So the lesson learned from this project is a multi-sectoral data integration and use is very crucial for the evidence-based informed urban health policies. Next, please. So the major takeaway from these two studies, as well as our work in the work with the federal actors and two municipalities, found that data and evidence are fragmented and they do not have the culture of the stakeholders do not have the culture of sharing due to their own interest. And evidence is not always prioritized because of different internal and external barrier. Multi-sectoral notion is largely undermined among the stakeholders. The institutional capacity is lacking in both individual and organization level. So urban health is very important part of primary healthcare, but local government face major capacity challenges such as staffing and financial challenges, which hinder the urban health strengthening system. Thank you.
Thank you, Abika. I think, yeah.
Hi.
Hi.
Good morning. This is Selassie from the University of Ghana. Thank you, Abigna, for your nice presentation. Can I go ahead?
Yes, please.
Okay, so for Ghana's Project 1, we aim to work with communities, local governments, and then health workers to support health promotion and preventive policies and programs at the household and community level for its dwellers across the life cycle. And so the main aim was to co-produce with the stakeholders and also evaluate whatever interventions come out from our engagements with the various stakeholders. Next slide, please. So a bit of context for Ghana. Currently, NCDs contribute to about 43% of all deaths, and almost a quarter of these deaths are caused by NCDs. Or a quarter of these NCDs deaths are cardiovascular diseases. So we see also a rising burden of NCDs among the urban poor. And so this double burden of NCDs and communicable disease of infectious disease exists now within the urban poor, even in Ghana in general. So our study was in Medina municipality and then Ashaiman. And within this context, when we did our baseline study, we saw that about a quarter of our population, our study population, had a prevalence of hypertension, a third of the population were overweight, obesity was also on the increase, and then a third engaged in occasional tobacco smoking. And then when we look at in terms of the healthcare issues or healthcare services, and there was a gap in preventive and promotive health services, which was being offered by the CHIPS when you come into the Ghanaian context. So these disease burden alongside what gaps existed in terms of healthcare delivery in Ghana. Next slide, please. So we took up a participatory action research approach. As I mentioned earlier, we were engaging with diverse stakeholders, community members, health workers, and then local government officials. And the goal was to collaborate with these different groups to design and implement health interventions that sought to tackle the double burden of CDs and NCDs, by focusing on NCDs because of the growing of these among the urban poor. Next slide, please. So I think when we went into our communities, we were trying to find out what healthcare options were existing, especially for primary healthcare. For Ghana, the main vehicle was for primary healthcare is the community health planning and services, which we call the CHIPS in short. So we realized that the range of services for the CHIPS was not really known to the community members or the residents within the urban poor population. And there are misconceptions about what the CHIPS offered. And the health workers also mentioned about the restraints they had with the logistics and apparatus they needed for their work. And within the health workers, we also found out that they had limited knowledge on emerging urban health issues and how they could intervene among the urban poor. So these were the things we found. And then we decided to engage with the same stakeholders to find out how we can intervene. And then we ended up with 3 main interventions. Next slide, please. So our interventions are is a package which is 3-pronged. Next slide, please. Yes. So first of all, to empower the health workers, which are the community health officers, educate or create an awareness about what CHIPS could offer, and then also give the community or the health workers some apparatus to work with. So in doing all these, we were able to reach the community members with the range of services the health workers to provide. They started checking the blood pressure, checking sugar level of community members. And then with that, we were able to engage with the Policy Planning, Monitoring and Evaluation Division of the Ghana Health Service, which the director was able to create a liaison desk for urban health issues. And they collaborated with the CHORUS team, and they formed also a technical working group, which supported us to design a curriculum to train these health workers who are working at the CHIPS level to be able to provide the services they had to provide. And so this is one of the things that we have been able to do within the Ghana Health Service to create a liaison desk. And then the other thing that in terms of policy we've been able to achieve was to also make inputs into the CHIPS revisions that the guidelines that have been done. Because of the work we're doing, we're raising awareness about the fact that urban CHIPS needed to be redesigned so that it could fully meet the demands or the needs of the urban poor in terms of NCDs. So PPME was designing a revision, and they gladly brought CHORUS on board. We look at the guidelines, we make our inputs, and then based on the curriculum we had also developed for training the health workers on NCDs, reproductive health, and then mental health, we provided this document as a supplementary training resource that the government of Ghana could use to train health workers, especially those who are working in urban poor communities. Yeah. The third thing that we did, next slide, please. Yes, was to also work with the Health Promotion Division of the Ghana Health Service. As I said, we also found out about the low awareness of the range of services CHIPS could provide. So we work with them, and we produce jingles in English, in Twi, which is the predominant Ghanaian language, in Ga, and in Hausa. And these were played in public places, in community centers, were shared with health workers that they use for their outreaches whenever they go to engage with the community members. And the messages were highlighting that then these health providers could check people's blood pressure, check their sugar level, and which was something that was not being done. So this is now part of their routine services within the Ashaman and Medina municipalities. And we are very happy that these are being done now. And in terms of visuals, we also created posters which they display advantage places within the communities for people to see, and then are also informed about the services that the CHIPS can provide. I think the next slide has samples of the posters that we designed. Next slide, yes. So the first slide, which is the AI sample, was what the concept was. And then we went into the communities. People volunteered to take pictures, which were used for the posters so that they could also connect with the posters that were being designed. So we had one poster for the Ashama municipality, another poster for the Medina municipality. So in a nutshell, we are happy that within the duration of the project, CHORUS has engaged with the grassroots or the people who are recipients of the service, engaged with policymakers, and we can see CHORUS's work being embedded into what Ghana Health Service is doing. So that is the Ghana story, and we are happy about how far we've come with our work among NCDs. Thank you.
Over to you,
Hi.
Deepa.
Thank you, Brian. Am I audible?
Yes.
Okay, brilliant. Hello, everybody. So today we'll be presenting how the chorus work has impacted the NCDs in Bangladesh within the urban primary healthcare system. Can we go to the next slide, please? All right, so this is just a very, very brief overview. So as you can see on your slides, on your screens, the urban primary healthcare system in Bangladesh is extremely different from the rural primary healthcare system. While the rural does have a particular structure, the same can't be said for the urban primary healthcare system. So I guess it's just a pluralistic part of things. Can we move on, please? So identifying the fact that the urban primary healthcare system and NCDs didn't necessarily go hand in hand, the Chorus Project 1 in Bangladesh had three particular phases, where the first phase was the needs assessment, where we've used a mix of methods to identify gaps using the health system building blocks. The next phase that we eventually got into was to co-create an intervention package, and eventually we implemented the package and evaluated it using a difference in difference design with the process evaluation embedded within the system. Can we move on to the next slide, please? So in the co-creation context, as we've mentioned previously, in the needs assessment phase, we identified gaps using the health system building blocks, which were then presented to our key stakeholders from the Ministry of Local Government, Ministry of Health and Family Welfare, and other development partners. We prioritized which gaps we would like to address. So we prioritized gaps in service delivery, health workforce, and in health information system, following which the Chorus Project 1 focused on implementing and evaluating, firstly, the pen-adapted national protocol for management of diabetes and hypertension. Second, training the healthcare workforce. And thirdly, strengthening the health information system for NCDs using the Simple app. Can we go to the next slide, please? Now, I'm just going to move on in the constraint of time. We'll just move on to the implementation and evaluation of the implementation of the intervention. We used the REAIM framework, which is again on your screen. So we wanted to find out what proportion of the population the intervention reached, how was its effectiveness, what extent and the types of different facilities were they able to adopt and implement, and the maintenance after 6 months. I won't go into a lot of details, but we've got a very initial findings. As I've mentioned before, we used a quasi-experimental difference in difference design with an embedded process evaluation within the mentioned framework. So as you can see, we've actually evaluated through urban dispensaries and NGO clinics, having an equal sample size both pre-intervention and post-intervention, and both in the control and the intervention sites. We go to the next slide, please. So the primary outcome, our primary outcome for the Chorus Project 1 was to check about appropriate management. What appropriate management had, we'll discuss about it in the next slide, but primarily at this moment, what we noticed was in the intervention facilities, where in the pre-intervention, there were the proportion of population aged 40 and above, only 6.73% had been managed appropriately before the intervention was given in the intervention sites. That increased over a period of time to around 36%. While the same can't really be said for the control groups, obviously. So in the control, while in the pre-intervention, there was still around 6.34% of the patients were managed as required or as appropriately as defined. Over a period of time, it just increased to around 9.07, 9.1%. So that was, and overall, when we did the difference in difference analysis, we noticed that there was a 26.5% improvement in appropriate management, with the 95% confidence interval of being between 20.4 to 32.7. And we kind of found that the findings were significant. Can we move to the next slide, please? Now, when we say appropriate management, we've had a couple of definitions. So one was screening for diabetes, screening for hypertension, diagnosing for hypertension as per protocol, diagnosing for diabetes as per protocol, prescribing as per protocol, and counseling, and also asking for follow-up. So what we've realized is while the screening improved profoundly for hypertensive patients, that was around 63%, it also improved by 31%. The screening for diabetes also improved by 31% across the centers. When it came for diagnosing diabetes, using the protocols rules increased by 19%. However, there was no significant change when it came to diagnosing hypertension across the centers. On the other hand, when it came to prescribing medications, 36% of all of the patients were prescribed hypertensive drugs as per the protocols. However, no significant change was found when it came to prescribing medications for diabetes. And lastly, there was an increase of 32% proportion when it came to counseling providing counseling regarding the amount of salt, sugar, physical activity, so on and so forth. So these were the components which together formed the appropriate management. Can we go to the next slide, please? Now, these were the sites across which the intervention had been provided. All of them were the intervention sites. The AX are the ones who are which are the GODs, the urban dispensaries, and AYs are the NGO clinics. As you can see, I won't get into too much details, but as you can see, there has been quite a significant improvement across all of the centers. Can we go to the next slide, please? Additionally, also when it came to appropriate recording, due to constraint in time, I won't go into the definition of what we said as appropriate recording. We've got a protocol paper for that. We'll send you the link for that. But when it came to appropriate recording, and we used the simple app to kind of strengthen the NCD reporting. Again, in the intervention sites, it showed a great improvement. While only 0.74% had been recorded previously, that increased to 42.16% of patients being recorded using the simple app or using any form of recording elements. However, in the control sites, as they didn't have any specific NCD reporting register or anything at all, we still wanted to find out which elements have been reported. In fact, what we've noticed is in the control group, it kind of fell even further. It was 0.15 in the beginning, that went further down beyond, it went to 0 during the post phase. So that was something that we found quite interesting. Can we go to the next slide, please? In terms of the policy implications, what we've been able to find out and what we would like to recommend is, firstly, as the urban primary healthcare system in Bangladesh is under the Ministry of Local Government and Ministry of Health as well, there is a very, very important call for strengthening the interministerial coordination. The community engagement needs to be strengthened. The health system cannot function independently without community engagement, so strengthening it is of high priority. Thirdly, the urban primary healthcare workforce definitely needs to be included within the planned capacity strengthening activities of Ministry of Health and Family Welfare. Fourthly, services provided at the urban primary healthcare facilities. At the moment, a lot of people have a presumption that these are only for maternity and child healthcare. However, it's high time that these services have to be provided in accordance with the national protocols of the country. Next, the procurement of the medicines within the urban primary healthcare facilities definitely should be as per the essential medicine list. Fine. And second, lastly, integration of facility-wise data from urban primary healthcare facilities needs to be entered into the DHIS2 for transparency across the ministries and also across the population who want to get access to the national dashboard. And last but not the least, the allocation of budget in line with the essential health service package is of prime importance. I haven't added slides regarding this. However, everyone would be pretty much really happy to know that after chorus, which is still ongoing, we are very proud to say that the Dhaka North City Corporation, following the chorus project, has scaled up the protocol training to around 200 healthcare workforce of their own, and they've done 2 sessions of training, right, at one direct training and another refresher training. So that's definitely something that we're extremely proud of. And in addition, the non-communicable disease control program of DGHS, they also supported scaling up the simple app across other government outdoor dispensaries and across Dhaka and Khulna City Corporation. So that's something which we find at least is a definite positive outcome of Chorus Project 1 in Bangladesh. With this, can we go to the next slide, please? I guess that's just it from me. Thank you very much for your time and patience. And yes, thank you.
Thank you, Abhaka, Salasi, and Deepa for your nice presentations. So I will now go to our esteemed panelist. So the first panelist with us is Professor Moloy Kantimridha. Can you hear me?
Yes.
Dr. Moller. Yes. So thank you once again for joining. So you heard the three presentations. So the question to you is that the urban areas are facing high, burden of non-communicable disease. So what are the reasons of these increasing NCDs in LMICs like Bangladesh or Nepal? And do you think that our urban primary healthcare system in these countries are ready to deliver essential NCD care?
Okay, thank you, and thank you for inviting me to this webinar and on this day. So, and thank you for these questions. So, if we compare Bangladesh and Nepal, both countries have, very similar statistics about the prevalence of non-communicable diseases. And also in the urban areas, both the countries are facing like relatively higher likelihood of non-communicable diseases in the urban areas in both the countries. But what factors are driving this epidemic? So there are some similarity and there are some differences as well. So if we think about like behavioral risk factors, say for example, in both the countries, there is the nutritional transition that happened in the urban areas. So urban population are becoming more, they are consuming more processed food. They're consuming like less fruits and vegetables. And both Bangladesh and Nepal, in both these countries, we have very high inadequate fruits and vegetable consumption. So, over 95% of population do not consume WHO recommended fruits and vegetable portions each day. And that is happening more in the urban areas. Apart from that, though Nepal has like more physical activity level compared to Bangladesh, and but it's still like in the urban areas, both the countries have like less amount of physical activity compared to rural areas. And we also have problems with health systems in both the countries. And in the urban areas, delivery of health system is fragmented, and that's why like there is no early detection of non-communicable diseases in these countries. But another driver is alcohol consumption, which is very less in Bangladesh, but in the urban areas of Nepal, alcohol consumption is higher. But in Bangladesh, like smoking is higher than Nepal in the urban areas. So as I mentioned, there are some similarities, some dissimilarities in terms of these behavioral risk factors that are driving this non-communicable disease epidemic. But at the same time, in both the countries, especially in the urban areas, like environmental risk factors, air pollution is very high. Both Bangladesh and Kathmandu in Nepal, Dhaka in Bangladesh, they are, always in the top ranking countries in terms of countries and cities in terms of air pollution. But these are like the immediate drivers, like air pollution, behavior risk factors. There are some drivers of these drivers, like rapid urbanization. There are problems with the governance and policy landscape in both these countries, like and the WHO recommended multi-sectoral actions, the policies that are needed to implement multi-sectoral actions and best buys. So these are very weak, and also, the implementation of the multi-sectoral plan is actually not there. So these are the primary reasons why we are having non-communicable disease epidemics in these countries. But your second question was about like our readiness, like in Nepal and Bangladesh, whether we are uh, able to provide services to people suffering from non-communicable diseases. Um, and I was listening to the presentations today, and I also know from the literature review that, I mean, mm, there is a huge problem of non-communicable disease in the urban areas of both the countries. And I would say that like we are still not ready, despite the success stories from Chorus and despite other initiatives that are taking place in both the countries. So in Bangladesh, like we are not ready because of one problem that is our urban health system is fragmented because of some high-level management issue. So it's like a health ministry and also the local government ministry. So they are still not coordinating enough to make health system work better in Dhaka and other urban areas of Bangladesh. And that's why like there is a huge population in the urban areas and like the rural areas of Bangladesh, we are yet to develop a comprehensive healthcare system that can help people in Bangladesh, especially living in the urban areas, to access services and to prevent and control non-communicable diseases. In Nepal, the condition is a bit different, so far I know. But in Nepal, there is problem of social exclusion or exclusion of people from the services because mm, in the urban areas because they sometimes lack proper documentation in the urban areas, and that's why they cannot access services. So though these two countries are facing NCD epidemics, the drivers are a bit different, but there are huge similarity in the drivers. These two countries are identical in terms of prevalence of non-communicable diseases, especially major non-communicable diseases, and still despite some advancements, the countries, especially in the urban areas, the countries could not be successful to provide adequate care for its citizens living in the urban areas. Thank you.
Thank you, Dr. Malloy. This is, you highlighted a number of reasons for increasing NCT burden and the readiness. So it is all very helpful. Thank you so much. So I will now move to our next panelist, Professor Syed Zakir Hussain. My question to you is that what are the barriers we still could not integrate the NCD care in urban primary health care, especially in Bangladesh? And what measures government is taking to provide quality NCD care to urban population? What are the steps that you have taken as the former line director? And what are the plan for you for including NCD care in urban primary healthcare system? Over to you.
Thank you, Professor Momina Haq and other participants of this webinar, especially from the other two countries, Nepal and Ghana. And actually, we already heard the things you asked me uh, regarding the challenges. Earlier, Professor Dr. Molloy and Mridha told regarding the key drivers, that is the challenges. Uh, just I highlight few things. Rapid urbanizations, that's why there is lack of infrastructure, environmental degradation, and poor housing system. These are negatively impacting the health status of the urban population, especially the marginalized populations. So, urban, you know that in Bangladesh, I think it's also in the Nepal, so far I heard, the dual system of uh, the management of the health system in the urban areas. Especially in the urban areas, local government play the key role for management of the primary healthcare situation of the country of Bangladesh. And another thing, this really challenges. You know that primary they are not focused on the health, uh, the local government, and also the recently the urban primary healthcare project funded by the ADB has phased out, and city corporation need to bridge the gap and need clear policy and implementation plan. Ministry of Family and Health Welfare runs government urban dispensaries, that is the GOD, which are limited in number, only so far 20 in the Dhaka division. This is not adequate and not functioning as well properly. And the service utilization data on NCD from the urban healthcare centers are not reported, though we started through the CORAS and ARK. Only limited number of data right now we have in our hand. Uh, so 40% of the population living in the urban area. Though Bangladesh successfully implement their NCD management protocol in the Upazila Health Complex and a few districts throughout the country, we have success. Uh, uh, Only 53% of hypertension patient as of 30th October 2025 under control. Those who are receiving the protocolized drug, those who visited the our NCD corner at different rural areas. So we have established NCD management protocol. If we implement it is throughout the urban areas, I hope this will be more beneficial for our urban population, especially the marginalized population. But service delivery system right now, as I earlier told, only 20 GUD that are not yet structurally and functionally ready to serve the situations. And that's why we have to focus how we can address this thing. One of the way we are planning that if the medical colleges that are reside within the urban area, medical college hospital can take part for the primary healthcare services. HR is one of the major problem, infrastructure as well. So these two things can addressed by our junior doctor, intern doctor as well. They can provide service in these centers, as well as they also learn how to provide service to the people at the root level, grassroots of the people. Because you know that after passing, completing the internship, they are trying for the government job or non-government job. They have to go at the rural level. They have to orientate the how the government provide the primary health care services. So this is also a learning part of their training. Now these are the few things. Another collaboration earlier, the thing right now need more and more collaboration between the Ministry of Family and Welfare ministries, as well as Ministry of Local Government and Rural Development and the city corporations, so that we can work together. And we need a strong financial. You know, one of the important factor for control is the uninterrupted medicine supply. This is also the patient's counseling and educations. We know that these are the chronic diseases. One of the very important factor, people when feel good, they are forget about to take the medicine regularly. So we have to impose the responsibility towards the patient. That is your disease, your problem. You have to take this medicine regularly so that you keep your health in a good conditions, and you will not go for premature death. You know that one of our SDG goal is to reduction of 1/3 of premature mortality by the year 2030. So now, if the patient can understand this thing, they will be more aware regarding to take the medicine regularly. This should be also financial as well as health educators. It's not widely available in our country. We should manage this sorts of HR in our system more and more in numbers so that people will be more benefited. So far, this is about to me from my side. Thank you again for giving me the opportunity to share this thing with you.
Thank you so much, Professor Syed Zakir Hussain. That was immensely helpful, and it was always nice to get your perspective and some innovative ideas that you share, especially using the intern doctors and other issues that you raised. If we have time, maybe we can come back to you for another round of question, maybe for 1 or 2 minutes. But now I will move to our next panelist. We have Dr. William Bosu with us. Can you hear me, Dr. William?
Yes, I can, Professor Romana.
Yes. Thank you so much for joining. So we always talk about these, and the other, panelists also mentioned about the structured collaboration about different ministries and actors to improve the urban healthcare services, and also, to reduce the fragmentation. So, I mean, why collaboration is so difficult despite our interest of collaborating of different actors to prevent NCD, especially in urban areas. So how to enhance that? And also my question to you is also how to influence the policies at the global level to strengthen urban primary healthcare system to respond to the increased prevalence of NCDs beyond collaboration, of course. So over to you.
Thank you, Professor Romana. When we think about collaboration, we tend to think of it in at least 3 or 4 dimensions, though from the presentation that we had, we were talking really about the collaboration between the government, the Ministry of Health on the one hand, and other government ministries. But I dare say that there are challenges even within the same health sector. So Ministry of Health, different departments within the Ministry of Health collaborating with each other. A case in point is in Ghana, where there was a time where tobacco control was held in a different department from NCD department. And I think there's still the case for quite some time if we talk about obesity in the context of urban health, then it's non-communicable diseases. But if it's undernutrition, then it's the nutrition program. And sometimes it gets even more confusing. So when there is marketing of food products to children, as a recent study showed, that there are billboards around school centers and so on. We have a maternal and child health or reproductive and child health services. We have nutrition service. We have the non-communicable disease control programs. So we tend to have, even within the same health sector, the differences in where these, the perceptions or the ambit or the scope of work of these different departments that should be working together. They tend to work in silos. We talked about the collaboration between different ministries within the government setup, a whole of government approach. There is also the collaboration between the Ministry of Health on the one hand and the civil society. And then the final one will be the collaboration between the health sector and the community. And as I said, it can be quite difficult. So a study in Ghana found that among civil servants, and the civil servants are among the most educated segment of the population, that the prevalence of hypertension was 30%. This was in Accra, urban Accra, and then prevalence of diabetes was 9%, much higher than the national average studies had shown. And what was interesting was that even among the civil servants, those who had hypertension, about 50%, nearly half, had evidence of target organ disease damage. And you think that there has to be some mechanism where there's some collaboration between the health sector and the public service who are really supporting services within the country. So at best, what you find is that there's a one-off medical screening. That is even a formal sector, maybe at the time of employment, and after that, nothing else happens. When it comes to NGOs, we're celebrating the World Diabetes Day. You find that some of the NGOs, they work in silos, they are fragmented, or there are multiple actors. So that makes it a little difficult to coordinate programs. So I used to work with the Ministry of Health as a program manager for non-communicable diseases. For quite some time, we're working with the Ghana Diabetes Association, which is part of the International Diabetes, affiliated to the International Diabetes Federation. Now we have the Ghana Diabetes and Endocrine and Metabolic Society of Ghana. So sometimes when there are multiple actors, multiple NGOs, each with their own funding stream, each with their own interest, becomes a little difficult to who do you work with? How do you work with all of them? Each of them has their own interest. So, and they may have a shared objective, but their interest in terms of rollout may be quite different. And of course, the community, engaging the community is always key. But often the community doesn't have the requisite information, or they don't have adequate information. And indeed, we tend to package our messages or our policies as if it was an individual action that required. So individuals are supposed to reduce their salt intake. They are supposed to avoid sedentary activities and so on. So where the importance of collective actions, community actions, the environmental drivers, air pollution, solid fuels, and all of those sort of beyond individual actions are not highlighted in our messages, and that really interferes with our collaboration efforts. I think that within that, I think that it's important to appreciate that we need to look for joint mechanisms where there is joint planning. In Ghana, there's a multidisciplinary sectoral committee for NCDs. But beyond that, they are supposed to fund different ministries and agencies are supposed to provide some funding for NCDs. But there's no real mechanism to monitor. There's no dashboard. There's no scorecard to indicate how much are you putting in, what sort of activities have you undertaken, and so on. So it's quite important to be able to monitor, set up accountability system. And it's important to use data for decision making. We've been talking about urban health, but when you begin to look at the data, the greatest increase in NCDs, in obesity, if you take overweight and obesity, is actually occurring among the poorest quintile, poorest households, where over the last 20 years in Ghana, there has been an increase of 115% compared to 35% in the richest households. So sometimes we do not use, yes, it's quite true that urban health is the way to go. And I'm quite happy that with the intervention from Ghana, the Chorus project, a desk was established within the PPME. But it's important that we use our data for decision making, and realizing that urban health is the way to go. We still need to recognize that the fastest growth is occurring in the rural populations. We do not need to, in the poorest populations and the rural populations, we do not need to wait till they become urban before we address those problems. So I think that just to sum up, it's important that we screen for, in the context of multi-sectoral collaboration, we screen for urban implications of all actions across the department, whether it's housing, transportation, all of that. How do these impact urban health in our society? Thank you very much.
Thank you so much. We are just nearly at the end of our webinar, but I just want to open again another round of questions just for 1 minute maybe, or 1.5 minutes to each of our panelists. So I'll again come to Professor Molloy. So what priority research can we do to strengthen the urban primary healthcare system, just to ensure quality NCD care? Research to strengthen urban health system. Over to you.
Okay, so if we talk about LMIC as a whole, so there is no magic bullet for proposed research. So each country should do its own research prioritization exercise, so that like they can find their priorities, because the country context, even non-communicable disease burden, differ from one country to another. But if I think about some kind of research, like what can be done in each of this country, because we have now evidence-based interventions for many of these diseases, how to prevent them and how to control them. But like the things we are missing is implementation at scale. So in all this, all the LMICs, there should be implementation research that needs to be done, so that like evidence-based interventions can be implemented. Most of the LMICs are facing environmental problems, and environment is becoming a large determinant of non-communicable disease. So we need to come up with solutions, how we also not only provide care for NCDs, but how we prevent non-communicable diseases. For these, like to design ways, so public-private partnership, reduction of out-of-pocket expenses, to those type of things can be prioritized, and also like how we can provide care to the urban poor, like, and reduce the disparity in terms of access to services. So those type of research areas can be prioritized. Thank you.
Thank you, Professor Molloy. I think we also have Professor Zakir with us still. Am I audible?
Yeah.
Yes, thank you. So, Professor Zakir, just very briefly, in a minute or so, if you can just say that how we can develop, the institutional capacity for data capturing, like strengthening DHIS2, so that we can include the urban data to DHIS2 for improved policy and planning.
Actually, recently we worked on it. We would like to develop a national NCD portal. We have different sources of data through the simple apps, through the Medonic lab, Spice lab, apps, like this. So if we coordinate these apps into a single apps, by ensuring interoperability among them, so that we can also have the private data as well. Now, these are the data from the government sources of NCD corners. So we need more trained staffs to improve the situation and integration with the DHIS too as well.
Thank you so much. We hope and wish that we'll move towards that in Bangladesh and also in other countries to capture urban data for improved policy and planning. So lastly, I will again come to Dr. William. Dr. William, very briefly, the same question, that institutional capacity development, in the government sector for strengthening urban primary healthcare system. So your reflection, what can be done? And especially, I would request to highlight the preventive care, also that how to promote the preventive care as well. So institutionalizing these within the system.
Yeah, thank you very much. I think one of the low-hanging fruits that occurs to me is the encounters that individuals make with the health system or the health sector, whether this be preventive or curative. So you find a patient who is obese or overweight making a contact who has diarrhea or who has malaria. And often you find that the malaria is treated and there is no intervention whatsoever. Whether it's counseling or investigating, whatever the risk profile that the overweight presents. So I think one of the ways is really adapt there has to be training of our health professionals, and also adapt our data collection systems. Our data collection systems are interested in diseases. They want to see pneumonia, meningitis, those kinds of diseases, hypertension. and not risk factors. So if you are smoking and you come with diarrhea, sorry, I'm interested in the diarrhea. So that is a way to go. And I think that it's important to inculcate the NCDs at all levels in all our professional training, whether it's whether it's nursing or pharmacy and all that. Thankfully, Ghana has started a pilot for a master's in public health in non-communicable diseases, and there appears to be some interest in developing some career path through non-communicable disease and urban health and public health related to diet-related NCDs. Thank you.
Thank you. Thank you, everyone, for joining. There is one question in the chat box. I think that has also been addressed about pre-service training and other issues. So given the time constraint, I think we have to close the session today. But I thank everyone for joining, and especially the three presenters and our esteemed panelists for their time and sharing their valuable insights and their recommendation for us. Thank you, everyone. Hope to see you all in our next webinar series.